Hello, everyone, and welcome to the Oregon Rural Health Conference presented by the Oregon Office of Rural Health. I'm Rebecca Dober, Field Services Program Manager and moderator of today's session. We'll start with some brief housekeeping. First, I'd like to thank our partners whose support has made it possible for the Office of Rural Health to present the conference at no cost to participants. Many thanks to our gold partners, All Care Health and the Oregon Rural Health Association. Our silver partners, Eastern Oregon Coordinated Care Organization and the Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes. Our bronze partner, RQI Partners, and our copper partner, Westcom and the American College of Education and Inquisic. Participants should have received an email with a link to the conference app, and you can use this app to visit our partners' virtual booths and enter to win prizes, network, and share photos of your region. Next.
Oh, come on. Don't screw it up.
And I'd like to quickly review the technical aspects of the platform. We suggest the floating panel view for the best experience. If you visit the upper right-hand corner of your screen where you can select the different options, you'll find it there. If you use the grid or gallery view, panelist boxes may block part of the slides on your screen. Your audio is muted and your camera is off. To ask questions, please use the Q&A box at the lower right-hand corner of your screen. I will ask the questions once we transition from the recorded portion of this presentation to the live Q&A. If you have technical questions about the platform, you can ask those in the Q&A box as well. If we don't get to your question, we'll be able to ask it in the evaluation. Or if you think of one after the fact, you can email the Office of Rural Health at ruralweb@ohsu.edu, and we'll post your question and the answer with the PDF of the presentation. Next slide. And please don't forget to do the survey about the session. Survey completion is required for participants seeking continuing education credit, and any completion gives you a chance to win a $100 gift card. Next slide. With that, let's begin the session about EMS in rural and frontier Oregon. Your presenter for the session is Dr. David Lehrfeld, EMS and Trauma Systems Medical Director at the Oregon Health Authority. And without further ado, welcome, Dr. Lehrfeld. The floor is yours.
Thank you so much, Rebecca. Thank you for the kind introduction, and thank you for sharing your precious time with us here at the OHA. This project, which is an attempt to quantify the challenges in urban, rural, and frontier EMS, is a multi-year effort on behalf of the OHA. The vast amount of work that has been done by our AmeriCorps Vistas. AmeriCorps Vista is a national service program designed to alleviate poverty. President John F. Kennedy originated the idea for the Vistas, which were founded as volunteer services to America in 1965 and incorporated into the AmeriCorps program in 1993. Vista's initialism for volunteering and service in America. And this project was started by Yvonne Sestimone 2 years ago, continued last year by Robert Edwards, who is now a full-time employee here, part of our data team. And our current Vista is Pachuri Patel, who continues the project into its third year. So we're thinking more and more about differences in access to resources between rural and urban areas. Often we hear about disparities concerning rural hospitals and other branches of healthcare, but it affects pre-hospital care as well. In Oregon, we've anecdotally suspected for years now that agencies in rural areas are not getting the resources they're needing, and they're struggling often in several areas of operation just to keep their doors open. So the objectives of this is to create a measure that could be applied to all licensing agencies that would determine the health of the agency. And in order to do that, we first needed to gather data on EMS agencies in Oregon, see what information we had, and then create a process to measure the data points, to use the data points from different areas of the agency's function to create a score. So we used the Office of Rural Health definitions for urban, rural, and frontier to categorize agencies. Urban cities with 40,000 people or more, 10 miles from the city center. Rural greater than 10 miles from a center of 40,000 persons or more. And frontier are 6 or fewer people per square mile. And you can see that in the Office of Rural Health map here. The dark green is frontier counties, the light green rural counties, and then the red and yellow, the centroids of urban clusters. So our initial method was to use a survey. The survey was created using a modified Delphi method where 2 groups of experts were posed the same questions and then their answers compared. And then the survey was sent out on eLicense, which is our licensing software for agencies, personnel, and vehicles. The survey included all licensed agencies in Oregon in 2018. So that was 134 licensed ambulance agencies, not EMS agencies, only ambulance agencies. And of course, because it was tied to the licensing process, we got a 100% return on our surveys. So there were 23 frontier agencies, the vast majority, obviously 83 rural agencies and 28 urban agencies. There were 16 questions, 15 multiple choice with multiple parts, and then there was 1 subjective question. These were all self-reported. So even though they might be objective, they still could theoretically be reported incorrectly. We surveyed again in 2019 and 2020. Based off the results of the 2018 survey, we changed some of the survey questions to drill down a little bit more, but some of them remain the same. It's not all directly comparable. We also accessed several other sources. We had the eLicense survey. We had the Oregon EMS Information System and Oregon Trauma Registry. The Oregon EMS Information System is at all the actual medical records of the calls that were run that would also contain information about the agency, about the personnel, about their level of certification, about the level of care provided, the volume of care. We wanted to get some well-rounded pictures, so we looked at agency demographics. We looked at internal data such as waivers, variances for equipment, personnel, and we looked at some historical OHA surveys as well as pulling the ambulance service plans. So if you're not familiar with it, every county has ambulance service plans with their unique geographic areas that one ambulance service works within. This system was created to ensure that all of the county was covered by EMS service, which is considered an essential service in Oregon. But it was also created to alleviate any overlap or conflict between services. There was a time before ambulance service areas where you might have 4 or 5 providers in the same area all competing for a single call with a little or no organization. So we looked at annual call volume, whether they were the primary ASA holder or working as a subcontractee or volunteer in the ASA. And we also looked at the type of service they were providing, as well as the number of ambulances and personnel. We looked to see if they were fee-for-service, some sort of tax base, or a combination of both, or none of the above. And when we collected all the data, we developed a scoring system based on certain survey responses that were determined to be indicators of the health of the agency. The assessment method used data points that are objectively positive or negative, except for 1, and each was weighted based on how essential it is to the adequate function of the agency and how the objective the data was. A lower score indicates the agency had a less stable infrastructure. So you could see them all. They have a variance for equipment, a variance for facilities. The one subjective question is, do you think you're adequately funded? Do they have a waiver for provider fees? How often did mutual aid have to come service your ambulance service area? Was there ever an occasion where you could not respond to a 911 call? And then staffing variances for BLS and ALS, as well as ambulance variances. What do all these variances and waivers mean? Well, they're basically saying that we can't meet the minimum regulatory standard for an ambulance or for a personnel or something, and therefore we're asking for this variance from the standard regulation because to comply with it would be beyond the capability of our service. So those are all very objective measures that an agency is struggling. So once we had our scoring system, we grouped them into one of four categories using Jinx natural breaks. A small explanation about natural breaks. They're used to find the best way to split data into ranges, finding clusters around means. If that seems a little abstract, I'd just point your attention to the graph to the right. There's an X and Y axis. There's a bunch of data plotted on it. You could arbitrarily, break this graph up into quarters and say, the first 25%, the second 50%, 75%. But you can visually see here that there's actual natural groupings within the data. And that's what the natural breaks formula does to you. It tells you if there are natural groupings within your data set and how many of them there are. So in our data set, it turned out that there were 4 natural groups. And we just color-coded them green, yellow, orange, and red. Green being the most positive, red being the most negative, describing, according to our assessment, the risk of that agency not being able to fully perform. So there were 55 agencies in the green, 36 agencies in the yellow, 30 agencies in the orange. And in 2018, when we first did this analysis, there were 12 agencies in the red. But 2 of those agencies have since closed their doors, agencies in the red. So there's some small indication that our scoring system may have some validity to it. So since not all agencies hold ASAs, we wanted to plot this out according to your ASA. So your ASA was either green, orange, yellow, or red. And what we found is that many of the red agencies or many of the red ASAs are near urban areas. Many of the orange ones are in frontier counties. And if you look at all the orange and red, so these are at-risk agencies, they're all in rural or frontier areas. So this generates some hypotheses. Why is it that the urban areas are green? And do urban agencies have adequate call volumes to sustain themselves? So they're primarily concerned with efficiency and coordination. Maybe frontier agencies have call volumes so low they know it would never sustain them. And mutual aid so far away they knew it would be independable. So they've adapted to have tax-based strategies to support their agencies. And what about the rural agencies? Why are rural agencies so often near urban centers? It could be that rural agencies near urban centers don't have sufficient call volume to sustain themselves, but they rely on nearby mutual aid in a pretty consistent manner to continue to exist. All things are knowable through the data. We just haven't had the resources to do those kinds of intricate analysis yet. But those are some of the hypotheses we're generating out of here and some of the things we'll look at going forward. So in the next year, when we started drilling down on some of these questions about, do you think you're adequately funded? Do you think you need help in certain areas? We came up with this. We examined the question, does your service need support or assistance with any of the following? Ambulance service area planning, billing, connectivity to your county government, connectivity to your local healthcare partners, connecting with your local community, equipment, medical direction, mutual aid agreements, recruitment, or other. So this was really interesting data. A total of 59 agencies, almost half of all licensed agencies, reported they needed assistance with recruitment, with 42 of those agencies reporting they need assistance with equipment as well. And you can see the three bars, the color breakdown of rural, frontier, and urban for each of those. So this trend held steady from 2019 to 2020. We also found that rural and frontier agencies are more likely to report needing assistance than urban agencies overall. And they tended to report needing more assistance with recruitment and equipment, which I found fascinating and generates another hypothesis. Urban agencies tended to be more preoccupied with mutual aid agreements. Per our previous hypothesis, urban agencies are concerned with efficiency. Mutual aid. Can a non-transporting fire agency get to the call quicker and, quote, stop the clock? Many ambulance service area plans, well, all ambulance service area plans have response times as the primary way of measuring compliance. And since there's more fire engines out there than there are ambulances, if you can get a paramedic or EMT on a fire engine to an address, then you could count that as your quick response while you're waiting for the ambulance. And we often see these dual responses in urban areas. You know, the rural agencies here are concerned about staffing and equipment, presumably because they're not adequately funded. What I find interesting is that this perhaps is too narrow a view of what's going on. Certainly day to day, if you don't have enough people and you don't have enough equipment, that's going to be your concern. But it kind of ignores the bigger problem that the call volume will never be adequate to sustain the service in rural and urban areas. And so in order to have a healthy service, it's really going to be the county government, the healthcare partners, and the ASA plans that are remedy to the problems. You know, if you could think of some examples of how an ASA plan could remedy problems, there are often counties with population dense areas that are one ASA where you can sustain a living, and then they create another ASA in the rural areas instead of combining the two into one ASA, thinking that the denser regions are going to offset the costs of the less dense regions. And of course, county governments are the ones that formulate ASA plans, and so being engaged with your county and being engaged with your ASA planning can help to alleviate some of these disparities. Also connecting to your local healthcare partners. If your call volume is low and you can't maintain paid personnel and are relying on volunteers because of that, it's easy to understand that you can't pay a paramedic to be on duty for 12 hours if he's only going to run one call. But if that paramedic is working in a healthcare clinic or hospital in between calls, then you could easily offset the cost. So these trends are pretty consistent, and I think they're telling about the health of our agencies. Other things we're seeing in the data. On the x-axis here, there's agency population, in other words, the number of personnel that agency has. The y-axis is call volume, and there's just this beautiful linear fit between the call volume and the number of personnel an agency has. But there's this third variable that you can see here, and that's the color coding of the personnel. Are those agencies paid, mixed, or all volunteer? And you can see a beautiful trend that as your volume and your population, in other words, your number of personnel increase, your number of paid personnel increase. And as you go towards lower call volumes and lower amounts of personnel, it becomes almost exclusively a volunteer workforce. So ongoing, we need to explore more trends in the data that are playing out. Another interesting thing to look at is the economics of the agencies. So in our data, there's an estimate of revenue in the form of volume, dispatch, and tax revenue, and the size of the workforce and the age of the workforce. If we use these variables to create groups of agencies that are similar in terms of those characteristics, and grouping in this way, the algorithm has identified 4 major groups, similar to the way our scoring system on the health of the agency found 4 separate groups. Grouping the algorithm in this way, you can see these distinctively colored branches in this dendrogram. These are groups in the algorithm that are broadly similar based on the size of their workforce, the age of their workforce, their dispatch volume, and their tax revenue. And so now we can compare agencies on in different parts of this dendrogram to see exactly what those limits are in their call volume and in tax revenue and personnel that put them in one agency or in one group or another. Also moving forward, we want to analyze the data to determine which of these factors indicate the health of the agency. What are the foundational issues that cause an agency to lack an essential resource? We were able to determine that the population is a factor, likely because of dispatch volume, and therefore affects the agency's bottom line. We don't have data on organization and leadership characteristics of the agency, which were likely to play a role in their sustainability. But to understand which questions in the rubric were associated with each group, we use a correspondence analysis. This is a little bit busy, but the red arrows represent each group category, where the blue arrows represent question responses. So if you look at the red arrows here, there's low risk, medium risk, no risk, and high risk. Okay, so those are the group categories. And then the responses to the survey and how close they are, and the length of the arrow indicates that they're the strength of the association. And the angle of the arrow relative to each question groups it and the groups it's associated with. For example, you can see that examining the no risk group in the chart above, there's a strong association with agencies that responded they're not using staffing variances. So put another way, staffing variances would be a risk factor, and not having them would indicate that you were low risk. From this analysis, we found the 4 things that fell out the most, or that were most indicative of being at risk, was responding yes to no responses. That means that at least once this year you didn't respond to a 911 call. Using either of the 2 staffing variances available. Responding frequently to S-rallies, that means that somebody was having to cover you in your own ASA, that's mutual aid, was highly predictive. And actually the subjective response that they weren't adequately funded turned out to be pretty highly predictive as well. So looking for trends in the data like this, we're able to determine what are the factors that agencies should look at in determining their viability and how we can address them. The U.S. Department of Health and Human Services, HRSA, Health Resource and Service Administration, has an Office of Rural Health Policy. A few years back, they came up with a guide for community-based needs assessment, and they made it into a needs assessment tool. The purpose of the tool was for an EMS agency to open channels of dialogue with the community that it supported. And this tool was an assessment that covered such things as the community demographic and the EMS profile, an EMS agency self-assessment, an assessment of the healthcare system writ large that the EMS agency worked within, an assessment of the public safety system as it was integrated with the EMS system, the local politics, the school system, local, regional, media, and community at large. Our next step is to assess the agencies on organizational characteristics directly. To do this, we're going to use survey questions from the Joint Council on Regional Emergency Care. And these questions come from the aforementioned HRSA toolkit. These questions specifically target operations, finance, staffing, quality of care, and more, and will bolster our existing information about the agencies. The questions were designed for agencies and community partners that provide specific targeted ways to assess organizational characteristics. So there's 41 questions for the directors, 21 questions for volunteers and employees, and additional surveys for local county officials, for local health system officials, for local public safety officials. Over the next year, Pachuri Patel, our third AmeriCorps Vista, has contacted 3 at-risk agencies within 1 county. She's negotiating with 2 of them to be part of a pilot project for 2021. If these agencies agree, OHA would field the survey team to conduct the modified informed community self-determination survey. And then based on those results, the surveys would be offered as communications tools to agencies and counties going forward. So conclusions. We think that rural disparities in access to medical care, we tend to think of hospitals, but our survey has shown that rural EMS also faces many challenges associated with low revenue streams. And we're hoping on finding innovative strategies that rural agencies can employ to alleviate these disparities. And with that, I want to thank you for your time and open up the floor for questions.
Yep, and we'll, thank you, Dr. Lehrfeld. We'll now move to the live Q&A.
Hey, Rebecca.
Hi, everyone. Welcome to the live Q&A portion of the session. Thank you, Dr. Lehrfeld. I just want to remind everyone to post any questions that you have for Dr. Lehrfeld in the Q&A box, and I will be able to ask them for you. But one quick thing before we get to the immediate Q&A, Dr. Lehrfeld has a little bit of an update to add to the presentation.
Okay, great. Okay, so again, I want to thank the Office of Rural Health and thank Rebecca for having me on here. We have a slight update on our efforts to improve emergency care in Oregon, and we're calling that EMS modernization. This is a legislative concept by the EMS office for the 2021 legislative session to go along with public health modernization. By myself and Dr. Dana Sellover, the EMS director, who is on COVID bed staffing call right now, or she would be with us. So the purpose of this legislative concept is to create a comprehensive integrated emergency healthcare system that can recognize problems, determine which services a patient needs, and then deliver the patient to those resources. The theory behind this is a patient should receive the same quality of care no matter who they are or where they live, urban, rural areas. This goes along with the triple aim, right care, right place at the right time. What we're hoping this legislative concept will achieve is better healthcare through regionalization and coordination of emergency healthcare to reduce morbidity, mortality for time-sensitive emergencies such as trauma, stroke, cardiac, mental health, and other. It will improve triage and stabilization, improve transfer protocols from small general hospitals to regional referral centers. It will have stronger quality systems through quality improvement in data. It will enhance the quality of care and access to care for rural and minority populations that experience disparities in emergency medical care. And it will target time-sensitive emergencies to specialty care centers. And the last thing, and I know there's going to be a few questions on this, it will upgrade and coordinate the EMS response system with an EMS mobilization plan similar to the fire mobilization plan. So why now? Well, about 33 years ago actually, Dr. Daniel O up at OHSU noted large disparities in trauma treatment. depending on where the patient was treated, what hospital they were treated at, which depended on where they lived. Oregon responded with then Senator Kitzhaber, emergency physician from Roseburg, to establish a trauma system to reduce disparities in trauma care and lower trauma mortality rates. And they succeeded. We have lower trauma, we have the largest state trauma system in the United States, and we have lower than national mortality, despite the vast distances and rurality of our state. So in 2010, the governor's emergency healthcare task force met, and they recommended transforming the trauma system into an emergency healthcare system. It didn't move forward as a legislative concept. A little bit of legislation around stroke was established in 2011. But since 2013, the office has made substantial interim progress towards modernization and improvement. We've had small regional time-sensitive emergency systems grow up. The oldest one was the STEMI system down in Medford. Now they have STEMI and stroke in Bend, Portland, a few other places. But as it stands now in 2020, the systems have developed as far as they can get without further infrastructure changes to create a modernized emergency healthcare system. So what would this look like? Right now, we have sort of a fragmented system. We have at the state level, state EMS committee, state EMS for Children's committee, state trauma advisory board, state stroke committee. At the regional level, we have area trauma advisory boards. We have local time sensitive emergency initiatives that have grown up around stroke and acute MI. And then we have somewhat integrated these local preparedness coalitions that may or may not interact with our HABs. What we're proposing going forward is a state emergency healthcare board with standing committees for EMS, pediatrics, and time-sensitive emergencies to include trauma, stroke, acute MI, behavioral health, etc. And at the regional level, we fold our area trauma advisory boards and our local TSE initiatives into time-sensitive emergency boards that also has preparedness built into it for pandemic response, for wildfires, etc. In the future, would also like to build out our data systems. All right, so currently we have individual hospitals and agencies that look at their individual quality. In the future, we'd like to have state data systems that can see system-wide quality across the entire episode of care. That's from the 911 call to the critical access hospital to the medevac transfer to the specialty care center. Would like to integrate or evolve our data systems. Currently data integration is through matching algorithms from two disparate data sets. So we saw that in the presentation earlier. We'll do these data pulls from different data sets and we'll combine them using R or SAS or some other program to match the charts together. But in the future, we'd like to challenge our vendors through the RFP process to actually have integrated data systems. And the OHA is pretty adept at working with large data systems. We have the OHA EMS data system, we have the Oregon Trauma Registry, we have a partial stroke registry, we have an ED data set. And so integrating these systems to talk with each other, and more importantly, to give information back to the users about their own quality automatically without having to become a programming genius is our vision for the future. As part of the integration of the EMS system, would like to pull in the parts that aren't there already. So right now, we have EMS providers that work for, as individuals, trauma hospitals, and ambulance agencies, but there's a lot of emergency healthcare that's not within them. Our non-transporting EMS providers, other time-sensitive emergency specialty centers would like to integrate into the system. And lastly, would like to modernize our EMS mobilization response for disasters. Right now, the current model is that if you have an ASA, you sign mutual aid agreements with contiguous ASAs around you. If they can respond to you over geographic distances, they can. If they can't, they can't. There's no real system similar to our fire mobilization plan where you can contact a regional authority such as the fire defense boards, have the state fire marshal's office declare a conflagration, and send ambulance strike teams. Our legislative concept would mirror the language of the fire mobilization plan so that you could contact county OEM. County OEM could request EMS resources from the Oregon Health Board. So those are the major concepts. The way we have it mapped out now, it would be in two phases. So in phase one, if our legislative concept passes in 2021, we would redesign our advisory board structure to create the new state and regional emergency healthcare boards by combining existing committees. We would establish regional emergency healthcare plans. So we already have regional trauma plans, but we have regional stroke, cardiac, pediatric, and more, so should the regions need it. The regions would designate emergency healthcare centers, starting with our current trauma systems, and design other time-sensitive emergency centers in conjunction with the state healthcare board. And then we would follow up in 2023 with additional time-sensitive emergency center requirements. We would create an emergency healthcare registry out of the existing trauma, stroke, EMS registries, etc. There's a small piece of the legislation that doesn't really have to do with our modernization concept, but because we only were allowed one legislative concept, we had to put it in there. And that's that ambulance fees haven't increased since '97, and they no longer cover the cost of licensing. This isn't really related to this concept. We just had no other place to put it. So wanted to full disclosure that was in as well. And then phase two in 2023 would add new types of time-sensitive emergency healthcare centers, specialty centers to the existing trauma centers, and formalize the details of the time-sensitive emergency centers with the new board. In 2023, they would promulgate those PSE standards. And the second thing in 2023, based on models built between 2021 and 2023 by the state board, we would transform ambulance regulation into EMS regulation, modifying to establish comprehensive EMS licensing and regulation that includes EMS providers, transporting agencies, non-transporting agencies. PSAP, State Emergency Healthcare Board, would make the recommendations on how to do that. And that's the end of the modernization legislative concept. And I think we can go back to questions.
Yes. Yeah. Thank you, Dr. Lehrfeld. I know it's a really dynamic time for EMS in Oregon and nationwide, so appreciate that update to your presentation. We do have a couple of questions in the chat box or in the Q&A box. So I'm just going to jump right in. Brian Barcelona submitted a question. Dr. Lehrfeld, what do you think would be the top 2 to 3 disease areas most impacted by the issues facing rural EMS services that you just talked about?
So, is it the modernization?
I believe from the original presentation, the lack of, the original presentation about the state of rural and frontier EMS. So which do you think would be the top?
I think the answer is going to be the same for both, right? It's time, what differentiates emergency medical services from just medical services is the time sensitivity of it. So if you look at time sensitive emergencies, those are going to where EMS is going to improve your your entry into the system and how rapidly you get resources, it is going to be those time-sensitive emergencies. So by numbers, it's stroke, trauma, acute MI, and then out-of-hospital cardiac arrest. That's by pure numbers. You can also quantify it by the time sensitivity of it. So for that, out-of-hospital cardiac arrest is going to be number one, right? Because you literally have minutes. You're never going to solve that entirely with EMS. You have to solve that with community engagement. I mean, people have to be doing CPR on you immediately. Your PSAPs, your 911 centers have to be directing callers to do CPR. We successfully, with the American Heart Association, passed a bill, was it 2014, Rebecca? For CPR and AED training, K through 12, mandatory. So it'll take 5 to 10 years for that to start showing up in our cardiac arrest survival rates. But by time sensitivity, it would be cardiac arrest, and by pure volume, it would be stroke.
Great. Okay. We have another question from the Q&A box. When it comes to fragmentation and inequity of resources, creating decreased access to care, pediatrics seems to be the gold standard of imbalance with almost no specialists or advanced care available outside of Portland. How does a rural pediatrician help?
So this is a question from a rural pediatrician.
From Rebecca Muller, yeah.
Okay, well, yes, so to be a leader in our rural emergency care system, we have our EMS for Children's program. Our EMS for Children's program has recommendations that every EMS agency should have a pediatric coordinator and a pediatric champion. So these are physicians and nurses that are involved as medical directors, as associate medical directors, that specifically work on pediatric issues. You know, as you mentioned, when you looked at our legislative concept, you notice that pediatrics got its own subcommittee, and that's because everything that the time sensitive emergency committee and everything that the EMS committee does, every project or every quality issue that comes out of there has to be put through a pediatric lens, right? So if there's going to be a state trauma plan, there's the state pediatric trauma plan, which is actually something we were working on before the pandemic hit. So if you want to help with rural EMS care, then form a partnership with your rural EMS and become their pediatric champion, become their pediatric expert. There's very few of us that are dual boarded in pediatrics and EMS, and those rare gems are usually usually found and captured by big cities like San Francisco. So anything you could do to get involved with the emergency healthcare system would be extremely helpful.
Great. And we've got a couple more questions. The next one is rural EMS using telehealth in any capacity? And that is from the Office of Rural Health Telehealth Coordinator.
I do not know that. I would have to trying to think how would I find that out. I suppose we could put out a survey. But yeah, that's a great question. I don't know if any EMS agencies are extensively using telehealth at this point. I don't know the answer to that. But if somebody knows, please let us, drop it in the chat box.
And another question, David Cracky, it looks like. Will there be an emphasis on the documentation of signs, symptoms, and behaviors consistent with a traumatic brain injury during the triage improvements?
Well, hopefully there already are. The area trauma advisory boards put out the current standards for the regions. So they're, let me put it this way. Once again, right before the pandemic struck, we were working on ideal documentation toolkits for time-sensitive emergencies. I hadn't thought to break it down to TBI versus trauma, but based on the work that happened in New Mexico, a documentation, but also an ideal treatment strategy, performance improvement project could be done around that. It could be done at the state level. It could be done at the regional ATAB level. But as far as the question of documentation, we could do that. What the ones we had planned on doing were, we've already done one on COVID and enabled new data points on that. We were going to do one on stroke next, and then trauma third. A lot of the projects we've been working on have been put on hold for pandemic response. But that's an excellent idea to do one just on TBI.
Yeah, and you actually bring up a really good point, which was probably what will be our final question in a couple of parts. How has the public health emergency impacted the work of the Health Authority EMS and Trauma Systems program? And are there any temporary changes due to the public health emergency that are helping maybe position agencies more strongly that might become permanent? How is the PHE impacting your work?
Yeah, so it's impacted every program in public health. You would think that during the pandemic of a century, the states would rapidly upstaff their public health departments, but for logistic reasons, that's just not what happens. It's just that all the existing programs, from drinking water to EMS, have to turn their attention to the public health crisis, and everything you were doing gets put on a back burner. You're probably getting a feel from that from my responses. As a result of this, most of our projects have been put on hold. However, Prachi, and I realized watching the videos, I was mispronouncing her name the entire time. So Prachi, I apologize. Is working on the community-based needs assessment. She's limited by her ability to actually travel and personally interact with the rural communities, but she is still working on that. A few other projects, we've got, most of our data team has been working on trauma and COVID, but if we can come out the other end of this, we'll see most of our projects around regionalization of pediatric trauma care, around our legislative concept move forward. I know we're running out of time, so the second part of the question was, are there temporary changes that happen for the pandemic that will become permanent? And the answer is yes. Some of them already have. So our emergency licensure rules have been made permanent. The Oregon Medical Board's emergency scope of practice rule has been made permanent. We have a draft of a state ambulance contract. It's basically a clone of the emergency one we've had, that will include immunizations, testing, ambulance strike teams, et cetera, that will be used for future wildfire response, future infectious disease. And I think we're going to see changes related to payment around transporting isolated patients and treating without transporting. I can't see those going away. Sort of like once you've opened once you've seen the potential of that, it's hard to take it back away. So I suspect those will be made permanent.
Well, and that brings us exactly to time. I just want to say, send our great thanks and appreciation again, Dr. Lehrfeld, for your participation, especially as I know you and many of the services around the state remain in active response mode. We very much appreciate your time and the updates. And just a reminder to all the participants, any other questions that you have, please send them in to us, and we will post them on our website with the recording of the session and the slides. And with that, I thank you all for joining us, and I hope that you'll be able to join us at 2 o'clock for our next session, making the case for community paramedicine in rural communities, evidence and lessons learned from around the state. We have a great presentation to follow Dr. Lehrfeld. So thank you, everyone. We appreciate it.